presenter of the day, Joel Bellesini, and Joel's project title is developing a 3D dynamic optical coherence tomography for ex vivo tumor margin assessment. So Joel, I've started the recording. Take it away when you're ready.
Cool. Thank you very much, Jake. So those of you who've been attending the weekly meetings might already know a little bit about this. But yeah, the full title for my project is Exploring Three-Dimensional Dynamic Optical Coherence Tomography as a Diagnostic Tool for Ex Vivo Breast Lumpectomy Tumor Margin Assessment. So specifically, we're looking at breast tissue, breast lumpectomy, tumor margin assessment. I'll explain what that is in a second. My project supervisors are Dr. Brendan Kennedy and Dr. Ken Fu from BRIGHT Lab, which stands for Bioimaging Research Innovation in Translational Engineering at the Harry Perkins Institute of Medical Research. Cool. So first of all, to explain what dynamic OCT is, I'll go into what OCT is first. OCT stands for Optical Coherence Tomography. It's a non-invasive imaging technology which uses the light interference of backscatterers within a region of tissue to depict internal microstructural detail. Can think of it sort of analogous to like ultrasound, but with light instead of sound waves, and this results in a higher resolution of but limited superficiality for tissue scanning, often applied in diagnostics. For example, this image on the right is of an OCT image of a healthy retina, and then an OCT image of a pre-surgical screening, OCT screening of a retina, which I believe is to be treated for cataracts. And there is satisfactory preliminary results in ex vivo application for OCT. However, technical developments of OCT continue to expand upon this applicability within the field of intraoperative diagnosis. And among these is dynamic OCT, which is the topic of my project, which implements tissue motion pickup using spatial-temporal variance on OCT. And I'll explain again what that sort of means in a sec, but to sort of hammer home the overall project aims will be obviously, first of all, to obtain and analyze high-resolution dynamic OCT images as validation of this novel medical imaging technique with reference to histology. This will be very important. So histology just sort of means referencing the actual tissue types of breast cancer patient samples after the fact, so that we can validate tissue type based on what we're seeing in our obtained images. But yeah, the main intention is to inspect, like I said, the functional capability of this modality in diagnostics. On the right here, we've got a schematic of what I mean by tumor margin, where we've got a negative and positive tumor margin of a lumpectomy or an excised region of cancerous tissue, where the positive margin essentially means that there is a sign of unsuccessful treatment, where there is still cancerous tissue amongst the edge of the excised region. And this is what's trying to be avoided, particularly in breast tissue. The delineation of cancerous to normal tissue is actually quite difficult for surgeons, because at the moment, the current status of breast conserving surgery is just through the surgeon essentially looks at it and sees if they can determine a margin between, I guess, what would be dense tumor tissue and healthy adipose tissue. But this isn't terribly reliable and leads to 20 to 30% positive margin, where re-excision procedures almost follow, and this obviously leads to more dramatic recovery times and clinical expense. So in following a lab-oriented goal, this research will contribute towards an active development in a more reliable, effective mid-surgical tumor margin assessment. There was a study done in 2020 where the lab engineered a handheld OCT probe, not dynamic, just OCT, but it's this sort of thing, and that was for in vivo assessment as well. But it's this sort of thing that is the sort of overarching goal of this research will be to be able to take a volumetric scan of a lump of excised tissue and be able to detect within a feasible duration of time whether or not the tumor margin is negative, and therefore it's been a successful treatment or not. So to talk a little bit about the actual system at hand, specifically, there's a few different types of OCT. We will be using what's called spectral domain OCT system, in which the method in which we gain our interferogram, which is an intensity over depth for a given region of sample, is by giving or providing a swept source input, which sort of acts as a scanning down the sample arm of different frequencies, which is then through Fourier transform converted into our interferogram. So what this means is we also get complex data for each, you see an intensity and a phase for each depth within a certain region of tissue. And this depth versus intensity is referred to as an A scan. And then we scan across a given spatial dimension to obtain a cross-sectional image called a B scan. And then for the dynamic OCT, what we're doing is we're taking multiple B scans in place. In this schematic on the left, there's it's been depicted as a time axis. This is sort of like a y-axis, if you will, where we're taking multiple B scans in place over time. And for example, here there's a particle which we could sort of see how motion can be extracted over analysis of, I guess, the Fourier information from each B scan over time. To sort of hammer this home, the processing will sort of entail the reduction of this temporal dimension into a single image, utilizing cell motility as this contrast modality. So frequency data gets extracted from our Fourier transform, which provides information on the spatial-temporal variance for each point. And the fundamental idea behind this is pretty important. It's that essentially we're looking for a sort of metric of motion for each point, in which case our Fourier transform will be a spectrum consisting of various locations in frequency, in which a point which might be of high frequency magnitude is therefore theoretically a result of heightened proportional tissue motion at that corresponding frequency. So the Fourier transform will essentially look different, have different peaks at different corresponding frequencies depending on the tissue type, which is where our contrast is going to come from. And obviously our range of detectable frequency of motion is determined by acquisition parameters. So acquisition parameters will be number of A scans per B scan, the duration or the delay between taking B scans, and line period, which means how quickly the system can take an A scan. This is obviously intrinsic to our system, which we're keeping consistent throughout the duration of the project. And the maximum detectable frequency of motion will be half of our B scan rate. The arithmetic is displayed here. Essentially, that's due to Nyquist sampling, which means we essentially want to have 2 points per wavelength in order to accurately sample a given frequency. So this can be sort of mitigated or for downsampling, but for the sake of accuracy, we want to stick to Nyquist sampling, in which case 35 hertz, then given a B-scan rate of 70 hertz, will be our maximum detectable frequency of motion. To do a brief literature review on the systems that have been employed to conduct dynamic OCT. Dynamic OCT has been performed on tumour cell spheroids and organoids in these two papers by Long and Scholler, and has only been tested on tissue scanning in a few instances, only involving epithelial tissue samples for dermatology and using full field OCT. So this is sort of where our novelty comes in, because it's sort of never been tested on breast tissue for cancer diagnosis. And also full field OCT is a somewhat limited OCT system, where 2D images are taken with a camera, 2D OCT images are taken with a camera in the on-fast plane. And what that means is we are sort of void of the complex information that I was mentioned earlier that we get in Fourier domain OCT or spectral domain OCT. So in our system, we're going to be looking at a new subject and using a new system, potentially with a greater density of information. So that's sort of where our novelty comes in. It's also yet to be exhibited in 3 dimensions on tissue scales, which is something that we're definitely going to be trying to do. The methodologies that have been done in the literature involving Fourier analysis will be integrated for validation in this project, and will obviously be used as a starting point for the development of a novel processing pipeline. These include frequency power analysis, which is what was done in the Long paper, and probability density distribution analysis in the Scholler paper. I'll explain what they are in greater detail in a second. We also aim to perform comprehensive quantitative analysis of each of these methodologies, as well as new methodologies on tissue scales, involving a few different metrics, including contrast to noise ratios, similar to these papers cited here. I've obtained figures. And just as a little bit of a side note, this project also encapsulates potential further development in more computational techniques, such as 3D visualization of tissue imaging, denoise modeling using AI, and even formation of a mode switching algorithm using a CGAN model. This is something which I've been talking with my supervisor a little bit over the past few weeks. Being able to turn an OCT image into a dynamic OCT image using some sort of mode switching model would be also another potential outcome of this project. But yeah, to explain a little bit about how the processing actually works, we take our OCT intensity over time and then take the frequency data of it, whereby the absolute component of the plot is taken and shifted to be symmetric about 0. And this methodology has been adapted from the long paper integrating spectral binning, which is sort of like averaging and separation of the spectrum into segments for later averaging, just to increase our signal to noise ratios, because we're obviously at the mercy of optical noise in this situation. And it's also useful to know that frequency data can also be altered in post-processing through resampling. So we can't increase our frequency limit, but we can, say, take every second point in our OCT interferogram and separate them into segments, and then therefore be looking at, with a greater detail, a lower frequency range, which means we can sort of inspect frequencies of different tissue motions at a greater detail. If, for example, in denser tissue, mainly we've got lower frequency motion that we want to look at, we can do that through post-processing, resampling. This is something which has also been displayed in the literature as well. So what the long paper did was what's called a power spectral analysis, where they took the spectrum and integrated it over defined frequency bins to get a metric of low, medium, and high frequency motion, displayed on 3 channels on a colored plot. So this is a method that we're definitely going to be validating, as well as what the Scholler paper did, which is a frequency probability density function type of analysis, where we treat our our frequency spectrum sort of as a probability density, in which we can obtain a hue, saturation, and variance plot, where these are all mapped to different metrics. The color will be the frequency, saturation will be it's the spectral width, which is like the almost a standard deviation around that frequency, and the value will sort of be like a SNR map, in which case we'll only be showing the points which correspond to a high frequency, and that is what's shown here on in this plot. It's like a continuous dynamic image now, instead of the discrete case for the long paper. But for what we're doing, there's also the potential to have a novel modality using the phase components. This hasn't been thoroughly looked into yet, but it's definitely going to be a source of interest for this project, because it's sort of never been done before. And that will be looking at, in the imaginary and real planes, seeing if we can get any sort of modality from complex information using something like a phase difference or a complex autocorrelation to inspect how our scatterers are providing information in the complex plane as well as in the real plane for a greater density of data. All right, so for data acquisition, we pitched to start with a dynamic phantom, which has been done. So this sort of, we made a phantom that sort of resembles like a blood vessel with a pumped polystyrene bead solution. And we've also so far acquired 3 breast tissue samples, 2 mastectomies, 1 wide local excision from Fiona Stanley Hospital. These acquisition parameters here are describing what we've done for the 2D case. 1,000 A scans per B scan, 2,000 B scans in place, and we've used the Thor Labs LSMO3 lens over a field of view of 4 by 4 millimeters. And then we've also done preliminary analysis on reduction of these parameters to sort of try and implement 3D d-OCT feasibility. It looks like we can reduce our parameters to what's shown here, roughly 400 A scans per B scan, 200 B scans per location, and a field of view of 3 by 3 to bring, to still have contrast, but bring our acquisition times down to a more clinically feasible level for the tumor assessment goal. And with a file size of 150 gigabytes, it's still quite computationally expensive. But in terms of clinical feasibility, this is still something that we are going to be investigating. And obviously, we'll need to co-register with histology. This will be essential for validating enhanced contrast of different tissue types by frequency, and we'll be using paraffin staining for this case. Here's an example of an image that we've got so far with histology coming back just to see sort of what it looks like, how we can identify different features, and then validate them against our OCT and dynamic images. So I know I'm conscious for time, but here are some images here of what we've got so far. Here's the HSV method on breast mastectomy. We can see definitely enhanced contrast and pickup of tissue type. The power spectral binning method doesn't seem to work incredibly on tissue scales. I think there'll be some adjustment of those power binning frequencies to make this work, because that's obviously a manual input. It's not as systematic as the HSV method, but we've also done on-fast imaging, which means 3D, and this is a slice over a duct within breast tissue to sort of show how we can still get contrast even when doing 3D acquisition parameters. A little bit on the cost and ethics. Largest cost in this project will involve the equipment used, in which the Thorlabs optical lenses must be operated carefully because they are shared and very expensive. Tissue samples are required patient consent and awareness of the study at hand, and will be shared across the lab for a variety of projects. So it's very important that we take utmost care with them. And finally, study plan. This is sort of where I'm at the moment. Phase 1 sort of can be ticked off. We've done literature review, preliminary image acquisition of a dynamic phantom for validation, writing of my scripts, imaging and 3D imaging as well has been done. And now I'm looking at sort of it's splitting into two fields of effort in data processing development and clinical evaluation. So that will mean on the data processing side, developing my scripts, investigating AI-driven models and complex information, contrast, etc., and 3D visualization. And then in the clinical evaluation, a more systematic and quantitative analysis of acquired images over different acquisition parameters to assess this clinical feasibility and histology co-registration. And then the final goals, once all of that can be ticked off, will be, generating figures for publishing, completing the thesis writing, and preparing a final presentation. All right, I would like to acknowledge the people at Bright Lab for contributing to this project, especially my project supervisor, Brendan Kennedy, and the UWA Medical Physics team, Pejman and Jake. Thank you guys for listening. If you have any questions, please let me know.
Fantastic work, Joel. Thanks for that presentation. Any questions?
I have a more biological question, if I can answer it. But I was just curious to know if the stage of breast cancer impacts just how much of the hard tissue is able to be detected. Like if you had a really early stage cancer, would the machine still be really highly effective at picking up hard tissue that might not be as differentiated in that cancer as compared to someone who has like a stage 3 or 4 cancer?
Yeah, so that's a really great question and sort of hammers home what we're trying to figure out. Essentially, there's a ton of different types of breast cancer. There's invasive ductal carcinoma, which is what most of our mastectomy scans will be, where essentially carcinoma forms within the ducts in breast tissue, and then that can either stay contained or it can metastasize throughout the breast. So the sort of stage in which the cancer is at any given point in time, we're not too sure as to how that will affect the dynamics of the cancer itself. I would assume not a lot. The main thing that we're looking for is just margin, so contrast between cancer and non-cancerous tissue, not really between different types of cancer or different stages of cancer yet, but that could definitely be a further point of analysis, different stages in cancer, seeing how the tumor actually evolves. But obviously, the sort of timescales that we're going to be imaging over are still only within the matter of minutes. So it's mainly going to be looking at biomechanical sources of motion of different tissue types, in which case the actual tissue type itself is probably going to be the most obvious change, not really the age of the tissue. But yeah, different samples will obviously have different types of cancer and stages of cancer, in which case that is another facet to sort of think about in terms of our validation of contrast obtained through our dynamic processing. Yeah, it's a good question.
Great, thank you very much.
Any other questions for Joel? Martin.
Yeah, Joel, so there's a lot going on in this project. It's quite ambitious, particularly when you started adding on the extra computational, like the denoising, AI-based denoising, the use of the phase information, etc. I guess you're thinking ahead with all of that potential work. What would you be what outcome would you be satisfied with?
I'd say those, as you've mentioned, these sort of further extensions within the actual processing development thing are sort of a little bit of a I don't want to say plan B, but a little bit of a if time permits sort of thing. Like I won't necessarily be upset if we get to the end of my project and we haven't really had the time to investigate these things. They are sort of things to fall back on those. So the main focus of this project is this clinical evaluation step. I would say that this sort of side of the project is what's a little bit more compelling and also a little bit more overarching in terms of the lab's overall goals. So that will be assessing clinical feasibility, how far we can push 3D d-OCT into potentially something that is clinical feasible and reliable for the desired outcome. The only thing is there have been many papers that have done dynamic OCT on more larger data sets than we have. I think there's a paper in the Biomedical Optics Journal that's done dynamic OCT on epithelial tissue, as I mentioned earlier, and they had something like 100 to 200 samples or something. So based on that, if we want to sort of have some sort of edge in the topic, that's where these data processing development things come in. Like the complex information is a source of enhanced contrast. If we can get that, then that's definitely an achievement and something which we could contribute towards a paper. But then beyond that, in terms of data processing, like you said, the AI driven things and the multimodal models and 3D visualization, they're ideas, but I wouldn't call them essential goals as much as the assessment of clinical feasibility would be, just to summarize.
Yeah, I think it's a good idea to have those alternatives there, and it's good planning.
Great. Thanks, Joel. I think we'll leave it there.
Cool.
Again, fantastic presentation. If you don't mind stopping your share.
Yep.
And we'll move on to Tom. Tom, if you're there, do you mind sharing your screen, getting your presentation ready?
Okay, sorry, Jake. Could you please stop
recording? Yeah, my bad.